Okay. Now, what we're going to do is the hepatoportal system, meaning the liver, pancreas, gallbladder, that whole system. This is long. These couple chapters are long and there's a lot of information in here, so I'll probably break this up into several videos. The things that are specific to the hepatoportal system that we're going to talk about are, we'll start out with like just some general liver damage stuff, and then hepatitis is our big one, so we're going to talk about hepatitis, and then we'll talk about cirrhosis. Those are your two major liver diseases, and then liver cancers, cholelithiasis, which is gallstones stones in the gallbladder. Esophageal varices is a problem, and lots of this stuff is caused by either a virus or alcohol. Alcohol is a big contributor to liver disease. So, okay, so let's get started. And right now I'm in chapter 49. And this first little bit is just review. It's just anatomy of the liver and kind of what the liver does. So, you know, if you've forgotten some of that, refamiliarize yourself and read those first couple chapters there. The couple things I do want to point out. And we talked a little bit about this with kidneys, but the liver does metabolize protein, and the big breakdown of protein is, it breaks protein down into amino acids, which you need, but then the breakdown of that is urea, and then that part gets excreted by the kidneys. So protein is excreted, is metabolized in the liver, so if you don't have a functioning liver, it can't metabolize the protein very well. But unlike kidney disease, we almost always increase or at least maintain protein in a patient who has liver disease. So we don't reduce it like we do in our kidneys patients, but we maintain it or increase it. Drugs are a lot of drugs, not all the drugs, but a lot of them are metabolized through the liver. So patients who have liver disorders are going to have higher levels of toxic, they can have higher drug toxicity levels. And this is really true with some of the over-the-counter medications. Acetaminophen, Tylenol is a big contributor of this because almost all of it gets metabolized through the liver. So your patients who are taking high doses of acetaminophen can start developing some problems because it's hard on the liver. And alcohol is fully metabolized through the liver, so patients who are drinking a lot of alcohol, that's what can lead to cirrhosis of the liver. As a person ages, their liver tends to decrease in size and weight. Your liver sits up here under the intercostal, right under the last rib. And when you lay your patient flat and you palpate, you should not be able to feel that liver. If you can feel the edge of that liver, the liver is probably enlarged and it needs further assessment. So, kind of read through that that first section if you're not familiar with the anatomy and how to do physical assessment. The other thing I wanted to direct your attention to is some common laboratory tests used in liver functions. You need to know that bilirubin is specific to liver because the bilirubin is the breakdown of red blood cells, and that gets filtered through the liver. And then your ALK-Phos, your AST, and your ALT, those are your very specific liver enzymes, and so those are the ones we watch for in our patients who have liver disease. Yeah. And then your cholesterol, your liver is responsible for your cholesterol, partly responsible for your cholesterol levels, so do kind of familiarize yourself with the laboratory values in table 49.1. Okay, now I want to talk about, in general, what are some manifestations of liver disease? Like, how do you know your patient's starting to develop liver problems? Well, number one is jaundice. Jaundice is just a yellowing of the skin, and the reason that happens is because the bilirubin levels start increasing, because the liver is supposed to flush out or metabolize the bilirubin. It's supposed to dump it into the GI tract, and it's the breakdown of red blood cells. The heme portion gets excreted into the GI tract, and then that's what turns the stool brown, is the heme part of dead red blood cells. Red blood cells live approximately 3 months, and then they die, and then they get broken up and discarded through the stool. Well, if the liver's not working and it can't conjugate the heme, and then with the bilirubin, then the bilirubin levels start getting too high in the blood, and the skin turns yellow. So, in the first place that you'll see the yellow showing up is in the sclera of the eyes, and then you'll get this yellow hue to the skin in light-skinned people. It's not going to show up in dark-skinned people as much, but the palms of dark-skinned people could start turning yellow, but the sclera is a dead giveaway. And that's an indication of high bilirubin levels and liver problems. So in a patient who has a suspected liver disease, you need to find out what's going on. So usually there will be some diagnostic tests like ultrasound or CT scan or MRI. Anytime your patient goes for a diagnostic procedure, that can only confirm general abnormalities. It can tell you if there's a mass there. It can tell you if the organ is enlarged, if there are anatomical structure deficiencies, but it cannot confirm a disease. The only way you can confirm a disease is through a biopsy. You've got to send the cells to the pathologist, and for the pathologist to figure out what's going on. So if, and this is true across the board, so if your patient has like a mass in their breast and they have a mammogram, the mammogram can show there's a mass, but you have no idea if it's a fibrotic mass or just a fibroid tissue, or if it's actual malignancy, until you go in and biopsy it and send the cells to pathologists. This is true in livers too. So if you have a suspicion there's something wrong with the liver, you have to go in and do a liver biopsy and get a piece of that tissue to send to the lab to figure out exactly what is wrong. Your job as a nurse is to prep the patient before the biopsy, and then to take care of that patient after the biopsy, and you do that by laying the person on the side where the biopsy was done. So they're going to lay on their right side. The reason is the liver is very vascular, so you want to put pressure on there, because one of the risks following a biopsy is bleeding. So you want to prevent that if you're going to assist, because a lot of those percutaneous liver biopsies are just done right at the bedside. Okay, so kind of, you do need to know about that. Another thing that you should be aware of with this is true with any liver diseases, is portal hypertension. When you hear that word portal hypertension, that means the arteries and the veins that are feeding the portal system, basically the liver. It's very vascular. Almost all the vessels go up through the liver because they need the liver to detoxify toxins. That's what the liver does. Your body develops toxins from, whatever, food, drugs, all that stuff has byproducts, and it's toxic to the body, and the liver detoxifies the body. So it's very, very vascular. But when the liver isn't working very well, those arteries and veins can get congested and full. Collateral circulation can start to develop out and around the arteries that are congested and hardened. and so it can become even more vascular, but those collateral circulation are very tortuous and thin, and they can burst and rupture very easily. So these patients are very prone to bleeding, and it's called portal hypertension. And you treat it just like systemic hypertension. You got to get that pressure under control because you want to prevent the bleeding. Liver patients are also at high risk for ascites, meaning extended fluid in the peritoneal cavity, because the liver can't drain the fluid like it's used to. So these people get very big, full, round bellies. Google image a patient with ascites. They look like pregnant women. That's what their bellies look like. And there's some ways to treat that ascites, that fluid in the peritoneal cavity. And here it is on the next page. And it's called a paracentesis. So when the fluid starts building up in the abdominal cavity, when you hear the word centesis, that means to drain. You can do a pericardial centesis, or in the abdomen it's called a paracentesis. And you can see this guy, I think it's hilarious, I'm on page 1347 right now. And this gentleman, this little figure sitting down here in the chair, the poor guy looks like, he's in some kind of a torture chamber. But what they're trying to show is that you stick a needle into this fluid and then drain it off, and they can pull fluid off. The problem with that much fluid there is it starts pushing up on the diaphragm. It makes it hard to breathe. It contributes to squeezing those vessels that are already compressed and under some pressure. So that's paracentesis. Another thing that they can do with somebody who has a lot of paracentesis, a lot of fluid in the system, is do a TIPS, a transjugular intrahepatic portal shunt. And what that does is it shunts the fluid into a vein, and then hopefully it'll go through the kidneys, and you can excrete it through the kidneys. And that's called a TIPS procedure. Okay, so that is general. So, some other things common to liver problems is something called hepatic encephalopathy. And what happens in hepatic encephalopathy is because the toxin levels are starting to get so high, the patients can get confused. This needs to be mentioned to a physician or somebody very quickly, because that means the toxin levels need to be addressed. So you watch for altered mental states, irritability, confusion, aggressiveness. That means that hepatic encephalopathy might be developing. Another thing that patients, when their toxic levels get too high and they start developing hepatic encephalopathy, is this thing called asteristics, where you ask them to put their hands out and their hands just start flapping tremors. That's called asteristics. And it's an indication that hepatic encephalopathy may be developing, so watch for that. Okay, I think let's talk about esophageal varices in this next segment. Yeah, let's do that. And then we'll stop it. We'll do viral hepatitis on its own video chat. So, esophageal varices are just like variceal veins. Like, have you ever seen like legs that usually occurs in older women, where the veins in the legs, they come out near the skin and they get real tortuous. They look like little worms or whatever. They can be painful, and the walls of those vessels are thin and they can rupture. That can occur inside the esophagus. It's often caused by excessive drinking, alcohol. So these varices start forming, and they can rupture. And when they rupture, it is a leading cause of death. It becomes a medical emergency because a person can exsanguinate, hemorrhage very quickly following ruptured esophageal varices. So it's varices can also develop when the pressure in the portal system starts getting so high, and remember I told you the collateral circulation starts to develop up and around the high pressure in the portal system, and so part of it is in the esophagus, and those can rupture. Your job as a nurse is to watch for that. You've got to be very, very careful and very vigilant that you are paying attention to esophageal varices, because you want to prevent them rupturing. You want to prevent them from occurring in the first place, and then you want to prevent them from rupturing, because a lot of patients die. People who have esophageal varices die if they rupture. So if your patient has liver disease or known portal hypertension or known varices, and all of a sudden they start increasing their heart rate, decreasing their blood pressure, losing consciousness, you can suspect that they have bleeding esophageal varices. Now, most of the time in the esophagus, the patient will also start vomiting up bright red blood because it's in the esophagus. If it's a little bit lower, like stomach bleeds, those have like coffee ground emesis, and even further down you might not have any bleeding, any evident bleeding. But in the esophagus you will get bright red blood. The person will vomit that, and that becomes a high nursing priority to assess for bleeding and assess that the varices are there, and then what to do about it. So you want to keep the person's blood pressure down. You don't want them to be too fluid overloaded, because you don't want to contribute to anything that might make those vessels rupture. There are some the best way to figure out if they're there is an endoscopy. An endoscopy is just a tube that goes down the throat. There's a light on it and a camera on it. It's oftentimes a cutting mechanism on there. The physician will go in and determine if the person does have esophageal varices. There are some ways when they're in there doing an endoscopic procedure to fix them. And if you look over on page 1352, up at the top in figure 4911, figure A shows an endoscopic procedure being done where they're visualizing the varices, and sometimes if the varices are more aneurysm-like, they can clip them or ligate them, put bands around them, and that will clamp them, so it'll prevent them from bleeding in the future. There's some other things they can do. They can do like sclerotherapy, where they kind of burn some of them. They can use, there's a medication now, look under pharmacological therapy. I'm back on page 1351 now. Sandostatin octreotide, that is the drug of choice if somebody is starting to bleed from their esophageal varices, and they give this sandostatin even before they do surgical interventions or balloon tamponade or something else, because that is a really good drug to constrict the vessels in the splanchnic the region. By that I mean the portal, like the liver, gallbladder, spleen area. It will vasoconstrict, compared to vasopressin. Vasopressin can also be used, but it's more general vasoconstriction. The problem with a significant vasoconstrictor like that is you have to make sure the person doesn't also have cardiac disease, because it will also vasoconstrict the coronary arteries, and it could cause an MI. So you do have to be careful, but if the person doesn't have a history of an MI or something, octreotide is the drug of choice. And then you go on and do things like increase fluid volume, especially if they're bleeding, because you don't want to, but you got to be careful because you don't want to go so much that you're causing the volume in the vessels to be too high. And you can do this thing called a balloon tamponade. They used to do it more often than they do now, but it's like they put a tube down the throat, and then they blow up this balloon, kind of like a Foley catheter, and it puts pressure on the sorry, those are irritating. On on those tortuous vessels, it puts pressure on there. It's just kind of like compressing an artery that's bleeding. Put pressure on it, it'll stop the bleeding. And then, if possible, you know, can get the patient to surgery and cauterize them and get them to stop. That's the best treatment of choice if you can get the patient to surgery. Okay, so let me see if that is all. We're gonna stop right there because my dogs are obnoxious. I kind of told you about what happens with hepatic encephalopathy. The next couple pages show you what some clinical signs and symptoms that is occurring in your patients who are developing hepatic encephalopathies. So, I mean, you can see there, like on figure 4914, how you try to get somebody to draw a star or write a sentence and they can't do it. That's a pretty good indication that encephalopathy is developing. Okay. All right. That is... Do kind of look through there because you can have some vitamin deficiencies. Pruritus is when like bile salts develop and then the skin starts itching. Another name for jaundice is icterus. So keep that in mind when you're looking through your medical literature and stuff. Jaundice and icterus are interchangeable. All right, I'm going to stop it here and then I'm going to come back. That just so you can just listen to one shorter lecture and then we'll come back and do viral hepatitis. Okay.